into our hospital on the day 5 of the child was unable to move right hand for last 1 day, ultimately bedridden, was unable to hold things with the right hand, raise, lift it down on the left-sided movement was normal, but he can turn from left to right side, but not on the reverse direction. The child was able to lift the head from bed. That was this left-sided weakness was associated with a deviation of the face. This right-sided weakness was associated with a deviation of the face towards the left side, and there was no drooling of saliva associated with it. The child could close the eyes, but the child was unable to speak in last 1 day, owing to an altered sensorium, and was unable to understand or obey instruction for the last 2 days. But he made unintelligible sounds inappropriately.
Please carry on.
No sound.
Yeah, and actually there was no history of loss of vision, double vision, deviation of eyeball, drooping of eyelids, numbness of face, difficulty in chewing, impaired hearing, nasal regurgitation of fluids, nasal intonation, drooping of shoulder, choking or gagging, or deviation of the tongue. There was also no history of loss of consciousness or a seizure or abnormal movements in this child. There was no history of abnormal twisting postures or flowing or distal breathing movement. There was no history of loss of perception to touch, to hot and cold fluids and painful stimulus. There was no history of bladder and bowel involvement, incontinence or retention. No history of trauma of the head and neck and the intraoral region. There was no history of perception of the heartbeat and the breath sounds by the child, bluish discoloration of the tongues or lips, mouth, and easy fatigability and increased sweating in this child. Also, there was no history of the preceding pain, abdomen, paleness, yellowish discoloration of the skin, pain in limbs, swelling of the body, blood transfusion, or any bleeding manifestation. There was also no history of any abnormal urine or body odor deposits in the body and any spinal deformity. There was also no history of preceding toxin ingestion in this child. Among the important past histories, the child had no history of similar illness of any episodes of hospital admission. He had no preceding fever, history of vaccination, of respiratory distress, vomiting, loose motion, burning micturition, rash, chronic discharging sinus. There was no history of fluid-filled skin lesions or ear discharge in this child preceding to this illness. Also, no history of photosensitivity, joint pain, abnormal gait, episodes of vomiting and confusion. From the family history, the child had no history of mental subnormality, seizures, cardiac defects, hearing or vision abnormality, bleeding disorder, malignancy, anemia, or premature death in the family. Also, there was no contact history of TB. Socioeconomic history of the child was residing in a pakka house while having 2 persons per room, where cross ventilation was present, and modified Kupuswami scale showed it as a lower child belonged to a lower upper to lower class. So may I go proceed to the initial examination in this child?
Okay, you finished the history, no?
Yes, I have finished.
Okay,
Hello.
now you.
Hello, Dr. Devlina.
Yes, ma'am.
Yes, sir.
After this history, now what are the possibilities you just gave
Yes,
from the history only?
Sir, the child had a right-sided weakness associated with the right-sided lower half of the facial palsy. So that is why there is a possible of the opposite side lesion, and which is more probably an upper motor neural type of lesion, which is involving a contralateral side hemiparesis and UMN kind of facial palsy, which I am suspecting from the history.
No, if you consider the whole history profile, now the fever of 5 days duration, altered sensorium,
Yes,
as well
sir.
as the right-sided hemiparesis. If
Sir.
this is so, then what are the possibilities in terms of disease, underlying disease or pathology?
Sir, in terms of underlying disease, I suspect this may be any infection, associated arteriopathy, or any bacterial infection, mainly because this is a history of a 5 days fever, and also there was a history of high grade fever in this child. And also there was other negative histories which ruled out the other possible causes which can cause arteriopathy or any cardiac abnormalities in this child, which may cause result into the this hemiparesis in this child. So I would go for an infectious origin, infectious on origin of arteriopathy from this history.
No, this is not per se the simple case of the childhood stroke of vascular origin. The whole history profile indicating that probably we are dealing with some intracranial infection. And the same thing, the acute encephalopathy, fever with acute encephalopathy. So bacterial meningitis other than the viral meningoencephalitis should also come in the picture. But the thing is that the hemiplegia or the focal neurological lesion is less common in viral meningoencephalitis. So if you compare between these two, the clinically the more possible underlying pathology is the bacterial origin. So other than these two, the same thing, acute encephalitis syndrome, differential diagnosis should come in the picture. So demyelination is also another. Very often the fever is also present in demyelination. So viral, bacterial, demyelination. So these are the three possibilities. And depending on the other thing, if the child belongs to the epidemic area for falciparum, then the falciparum malaria should come also in the picture. So broadly, these are the three possibilities.
Okay,
Dr. Ashok Datta, sir, your comment, please. Dr. Ashok Datta, sir. Or should we proceed for?
Yes,
There was
I present-
aphasia also. So can you
so-
highlight the child presenting with stroke, with aphasia, with a
No,
history
no,
of
it is
fever?
AES. That is clear.
yes. Dr. Sopon,
Yeah.
I would like to say this is a very good presentation, and definitely what Dr. Supratim clearly explained, that we should should not exclude the viral infection in this case. The should not exclude initially the viral infection, we proceed, and then we will find that sometimes some viruses may give rise to this type of presentation also. And there
Yes,
may
sir.
complications also. Yes, proceed.
Yes. So from the initial examination, when the child was drowsy, he was lying on bed, moving the left half of the body, but right half was extended with a minimal movements and the child was unable to communicate spontaneously. Anthropometric assessment, the child was well nourished, and the weight for age and height for age was 0 to 1 percentile, and BMI was also 0 to 1 percentile. The vitals of the child was heart rate 120, respiratory rate 28 per minute, BP 106 by 67 millimeter of Hg, temperature 90 degree Fahrenheit, spontaneous SpO2 is 100% with the room air, peripheral pulses were palpable. On general examination, the child had no pallid, cyanosis, clubbing, icterus, lymphadenopathy, petechiae, pedal edema, or signs of the raised JVP. In the head-to-toe examination, the child had no facial dysmorphism, no signs of the vitamin deficiencies, no spinal deformity, kyphus, gibbous, no hypo or hyperpigmented lesions, port wine stain, or xanthoma. The systemic examination I will be elaborating later. Now going to the initial CNS examination, the child was initially not oriented to time, place, person. The state of consciousness would be demonstrated as delirial state, while the level of consciousness would be GCS 9 by 50. The sensory and the cranial nerve examination, after the higher mental state examination, going to the cranial nerve examination, which could not be elicited because of the altered serum of the child, and only we have got the human kind of facial palsy from the inspection. Now from the the tone and the muscle. Now from the motor system examination, the muscle bulk was bilaterally symmetrical in this child. The right-sided tone was decreased, while the left-sided tone was normal. The power on the right-sided upper and lower limb was 0/5, but the left-sided upper and lower limb were 4/5. And the deep tendon reflexes were absent in the right side, while it was 2+ in the left side. The superficial reflexes were absent, abdominal and cremasteric reflexes were absent in the right side, while it was present in the left side. The plantar was non-responsive in the right side, but flexure response in the left side. Now, the sensory
Hello.
examination was also. The sensory examination was also could not be elicited in this child because of the drowsy state of the child. Now, going to the further after recovery, we had another CNS examination at day 5 post-admission, where the child was alert, conscious, oriented to time, place, person, having spontaneous eye opening, obeying commands, and attention span was normal. The speech of the child was altered due to the left-sided facial deviation, and after higher mental state examination, we had examined for the different low function. So the memory and abstract thinking, planning, judgment, and programming, problem solving attitude of this child was normal. The vertical sensation calculation and the geographical orientation, constructional ability, visuospatial function, right left orientation were also found to be intact in this child. There was also no only affected in the recent memory, only affected in the immediate memory, but there was no affection in the recent and the remote memory in this child. Also, smell, language, and hearing balance was normal. The cortical vision and visual memory was also examined to be intact. Now, for the motor system examination, the child had bilaterally symmetrical muscle bulk. The right-sided tone was increased and the left-sided tone was normal for the both upper and lower limb. For the upper right-sided upper limb, the power was 1/5, and the lower limb it was 1/5 also. For the left-sided upper and lower limb, the power was 4/5. The superficial reflexes of abdominal and cremasteric was absent in the right side while present in the left side. Plantar was extensor in the right side and flexure in the left side. There was sensory examination was intact in the right and left side both. All the autonomic and other autonomic examination was also intact, and there was no cerebellar signs and meningeal signs, and also there was no spinal abnormality. Now, my examination is over for this child. Can I proceed to the interpretation for the side of the lesion?
Wait, let the expert speak.
Devlina, stop.
Stop.
After the clinical examination, can you tell me, is there any feature of raised ICT in this child?
Sir, initially there was no hypertension, no irregular respiration or bradycardia. So I would not say there was any features of raised ICT in this child.
First, tell
Although
me
there was history of yes, sir.
First, what are the symptoms of raised ICT, then the sign, and are they present here or not?
Sir, there was a history of vomiting, multiple episodes of vomiting and headache preceding this illness on the day 3 of illness in this child, which would rather pointing towards the raised ICP features. But there was clinical findings were not corroborating of raised ICT in this child.
No, Devlin, I could not understand. He asked what are the symptoms and signs happens in case of raised ICT. Not in this particular patients. What are the symptoms of raised ICT? What are the signs of raised ICT? First, enumerate, then say whether these signs and symptoms are present or not. Okay, clear?
Ma'am, symptoms are like vomiting, headache. These were and signs were like bradycardia, irregular respiration, and hypertension.
What else? If another residents are there, please write it in the chat box. All PGTs are requested. If you know the answers, write in chat box. Yes.
Ma'am, Can remember.
Ashok Dr. sir says it.
Deblina, please go step by step.
Yes.
Dr. Supratim has asked you what are the symptoms and signs of raised ICT. This is a very important question, and this may come in different phases of your exam and day-to-day practice also. Now consider the different types of raised, how the raised intracranial tension occurs, what are the possibilities, and considering this you find out the symptoms and signs, not related to this case. Consider also other cases. What are the different types of problems which may happen? How it affects the midbrain, how it affects the cortex, how it affects the brainstem, how it affects the cerebral regions, and then give one by one symptoms and signs. As Dr. Supratim likes to know this answer, you give step by step answer. If you would know, then you tell, or otherwise you proceed. Sir will ask you another question, sir.
Okay, sir. There may be ptosis due to the uncal herniation, which is the raised ICP features, and due to the third nerve palsy, and step by step answer is. I think I'm not prepared. Step by step.
Deblina, cool down. You know things, say gradually and stepwise. What are the things you see from general examination, then cranial nerve examination, sensorium, all those features of raised ICT? What are the things you daily see? Just tell those things. And I think
there may be
Okay, Deblina, is there any importance of autonomic nervous system examination in this child, and any feature suggesting affection of autonomic nervous system?
Sir, autonomic nervous system, autonomic disturbances may occur and in this child, and there may be BP instability of the blood pressure and pulse, in which, or also bladder and bowel control, which may suggest any autonomic abnormality in this child. But in that case, there is no autonomic abnormality.
What are the autonomic nervous system examination possible in bedside in pediatric practice? The practical application of autonomic nervous system examination. So lots of the detailed examination is not possible, but in practice, in bedside, autonomic nervous system affection is assessed by which parameters? What are the parameters, I mean?
Sir, BP, first of all, postural hypotension can be assessed, autonomic nervous system can be assessed by the postural hypotension. There is a difference of the blood pressure more than 10 millimeter Ag in cases of the supine and standing posture. That is a postural hypotension. Then pulse, sir. Then any response to any stimulus, BP, changes of BP in any external stimuli, and also the Valsalva maneuver. This is also autonomic testing can be possible. Yes.
I think if there's no question from experts, mentor Arundhati, will you like to say something in this examination, up to examination part?
No. Another few points are there.
Okay.
So after the history and examination, Deblina, you just tell us what are the parts of the central nervous system which are affected, seems to be affected in this child.
Sir,
anatomical affection of central nervous system.
Sir,
from history and examination.
Okay, sir. Sir, first of all, the motor system examination is mainly affected in this child with the resulting right-sided hemiparesis and along with that,
complete hemiparesis. So which part of the brain is affected, likely?
Likely this is not above the spinal cord, and more likely this is the contralateral hemiparesis with the human facial palsy on the opposite side. So in the right-sided human facial palsy with the right-sided hemiparesis. So it is more likely
left-sided internal capsule. Left
left-sided
sided,
internal capsule
left
or
sided
cortical lesion.
internal capsule. Okay, so this is one area, and any other area of the brain seems to be, central nervous system seems to be involved.
Yes, sir. Cortical area involvement can be there.
So why,
Result into the hemiparesis.
why cortical involvement?
Sir, cortical involvement is also resulting into the upper motor neuron type of lesion was this is this is also the upper motor type coming into the upper motor type of lesion. So cortical lesion, internal capsule, all will be included.
The child
And
is
also
having altered, the child is having altered sensorium.
this child is having
Altered sensorium.
that is also there's cortical lesion maybe more.
Encephalopathy. Encephalopathy is there. Is there any affection, any feature suggesting cerebellar involvement in this child?
No, sir, there was no gait abnormality like tandem gait, or there was no
Tandem gait
nystagmus.
is not possible.
There
The
was no
child,
cerebellar sign present.
so what are the cerebellar signs? Suppose the altered sensorium is there, the child is bedridden. So what are the cerebellar signs you should look for, particularly in a bedridden patient?
Sir, first of all, eye signs, I can say dysarthria, which is standing speech, can be present in the cerebellar lesion. Sir, then as the child is in supine position, so gait cannot be assessed in this child. Now, the child can have, I can perform finger nose test or heel to shin test. And also there can be intention tremor in this child, which is also associated with the cerebellar lesion.
Ashok sir, please ask her.
Deblina, in your case, you started that there was aphasia. At the same time, the upper motor neuron type of lesions deviating the face to the opposite side. And there is alteration of the sensorium. So how much portion of the cortex should be involved? How much portion of the cortex should be involved in this case? What are the extent of lesions you expect in this case? Which
Okay, sir.
occurs without any
Yes,
convulsions, without any other things.
Yes, sir.
Which
Sir,
area of the cortex? Which area of the cortex should be involved?
for the hemiparesis and human kind of facial palsy, I think frontal lobe, mainly the frontal lobe, which is the primary motor area, will be affected. And but for the this kind of both the limbs, upper limb and mainly cortical lesions are associated with monoparesis. Hemiparesis is quite rare in cortical lesion, but there is an entire front left lobe or the bigger area of the left frontal lobe should be affected to result into this kind of lesion.
What is the difference of involvement between adult hemiparesis and pediatrics, childhood hemiparesis, in relation to the involvement of the cortex? Relationship. In relation to CNS involvement, in adults we usually see the internal capsule involved, but in pediatrics there is some difference. What is the difference of involvement of hemiparetic lesions between adult and pediatric agents?
In adult,
Which one is more common in case of pediatrics?
Yes,
Is
sir.
it internal capsule
cortical,
or the cortical lesions? Which one is more?
cortical lesions are more common in pediatric. Cortical lesions are more common in pediatric age. Because in adult, Charcot artery hemorrhage is more common, which results into the internal capsule lesion. Pediatric age group is not common.
So you see, in your case, there is no history of convulsion in spite of the lesion of the large extent. Can you tell any explanation? Can you say why it is so? Sarah has already given you the answer. So just find out the answer and
sir,
tell me why it is. Yes.
There was history of altered sensorium in this child, which is pointing towards cortical lesion.
Yes.
And also there was no sensory deficit in this child, which is also more because if there was an internal capsule lesion, there will be mostly associated with hemianesthesia. So that is also more going in
If
favor.
there
Also,
is-
the child was unable to speak initially. Yes, sir.
If it is a say, altered sensorium along with the hemiplegia in a lesion involving the cortex, you will have to involve the postcentral gyruses also. Sensorium is lost. Or there is some another explanation for this. What is the relation between the subcortical lesions and the cortical lesions, and what is the connections? Which area of the brain is connected?
Sir, in the
From the motor control and the central gyruses and cortex.
Sir, the awareness is associated with the cortical is controlled by the cortex, cerebral cortex, while the wakefulness is controlled by the reticular activation system, RAS system, which is the subcortical area. So, sir, there in the altered sensorium, the sleep-wake cycle, if it is preserved, then there is no involvement of the subcortical area. But if it is not preserved, then it is going more towards the subcortical area lesion.
Devlin, take a lesson that sleep-wake cycle is a different thing. It is not dependent on your say totally reticular activating system. It depends on the other structures which are present, and it depends on the balance between the different monoamines.
Okay,
And
sir.
there are three important monoamines are there. One is serotonin, second
Dopamine.
is norepinephrine, dopamine will come late.
Okay.
Serotonin, norepinephrine, acetylcholine. These three are most important for the wake cycle. And these are variable in different stages of the human wake and sleep pattern. So alteration of the sensorium in your case is involvement of the cortex. I required the answer that was a say encephalopathy, which uttered by Dr. Supratim nicely told you that the relation is there. Some involvement of the vasculopathy is there due to your cause of the lesions, and that gives rise to some encephalopathy in a wide area. And you do not get all the features of motor and sensory functions which is expected in about lesions in cortex in this case. Okay, proceed. Okay, Devlina, proceed.
Okay.
Devlina, signs of meningeal irritation absent.
Yes, sir. Signs of
You
meningeal
wrote.
irritation are absent. Cerebellar signs and meningeal irritation signs of meningeal irritation are absent. Sir, sir, is there any question, sir?
No, it's proceed. It will take a long time
Okay.
to discuss.
Yeah.
Proceed,
Have to finish by
proceed,
9.
proceed.
Have to finish by 9.
If president and chairperson scientific sir allow, then it will take long time for the discussion of this case.
Let her finish the case first.
Okay.
Then we'll discuss, and we are really elated that we have got another expert, Professor Apurva Ghosh has joined.
Welcome, sir.
Welcome, sir.
Apurva sir,
Welcome.
welcome. Please give some inputs about
Apurva.
from a history, and sir, I think you didn't listen the history. So examination part, I think you were there. So please give your expert comments on that.
Evelina.
Yes, sir.
Okay, so you have finished the history as well as the examination portion. So
Yes.
after doing this, you just put a case summary, then you tell the clinical possibilities over here.
Okay, sir. Sir, the 10-year-old developmentally normal, completely immunized child, completely immunized, well-nourished child with an uneventful birth history and born of a consanguineous marriage, presented with fever for 5 intermittent high-grade fever for 5 days, altered sensorium for 2 days, and right-sided weakness with a left-sided deviation of the face for 1 day, which was not associated with any drooling of saliva, nasal regurgitation or intonation, and difficulty in swallowing and chewing of food. There was no cardiac abnormalities. There was no joint pain or joint movement or joint pain or swelling in the abdomen, and also there was no associated of the abnormal movements, abnormal breathing movements or the dystonic movements, twisting posture or breathing movements, or any spinal deformity. Any from the clinical examination, the child had no pallid cyanosis, clubbing, or lymphadenopathy in raised JVP. The vitals were stable, and for initial CNS examination showed that the child had a right-sided hypotonic, right-sided complete hemiparesis with gross hypotonia, and power was 1/5 in the right upper and left limb, while the left-sided power was relatively normal, and there was a left-sided facial deviation. And also further CNS examination revealed the higher mental state of the child was intact with the intact lobar functions in this child, but there was only complete hemiparesis of the right side, with the lower part of the face was involved, which was more going on favor of the human kind of facial palsy. And there was spastic dysarthria associated in this child, but there was no aphasia, and cerebellar signs and meningeal signs were absent in this child. Also, autonomic functions were preserved in this child, and autonomic and sensory functions and other cranial nerve functions were preserved in this child. So from this clinical history and examination, the child, this is a case of a childhood stroke, and resulting from the arteriopathy, and the lesion of the lesion of the site of the lesion in this case is internal capsule or cortical area, and the probable cause may be infection or any autoimmune cause.
So why not acute encephalitis syndrome, the common term used by the WHO? Why this is childhood stroke? If you consider the whole disease spectrum, this is only a part of the whole disease process. The right-sided hemiparesis is only a minor or the one of the important component of the whole disease, whole clinical profile.
Yes, sir.
Why
Sir,
not the acute encephalitis syndrome?
Sir, although the child, although it was such acute encephalitis syndrome was suspected in this child, but the child had neurological, proper neurological deficit, which was persistent following the recovery from the fever and also the antibiotic therapy. So it was more going favor to the.
How do you explain the fever if it is a only case of simple stroke because of the arteriopathy? So you said that infective arteriopathy. Infective means the underlying infection is there. So
Yes,
the clinical diagnosis change. If you say that infective, then underlying infection either bacterial or viral or something else. So
yes,
the
sir.
whole
Yes.
diagnosis change then. So why not this is acute encephalitis syndrome, and the acute encephalitis syndrome, bacterial meningitis can be complicated with hemiplegia also, focal neurodeficit. It's not that uncommon. Monoparesis, hemiparesis, everything can occur. And if it is acute encephalitis syndrome, which possibilities you should keep, or the differential diagnosis you should keep over here? 10 days old boy with 5 days duration of fever. One is bacterial, another is the viral.
Bacterial
so of these two, which one is more likely, and why the meningeal signs are absent over here? So can you explain why the meningeal signs are absent over here? Either the bacterial cause or the viral cause. These are the two possibilities. And
Yes.
meningeal signs are absent over here. So why are they? Any explanation?
There may be signs, meningeal signs of meningitis.
There is a big child, 10 years old. So meningoencephalitis, so meningeal signs supposed to be present. And they are absent over here. Any explanation for that? And of these two, viral etiology and bacterial etiology, which one is more likely from the clinical presentation?
So from the clinical presentation, bacterial etiology is more likely, because because the fever pattern and the extent of deficit, neurological deficit, was more in favor of bacterial.
The
May I
meningoencephalitis.
request Professor Apurva Ghosh to say something? Sir.
আমার গলাটা খুব খারাপ আছে। I cannot talk
Okay, sir. Next time we'll get.
Next time, I have a severe sore throat.
Acha,
Okay, okay.
The Devlina, the thing is that the meningoencephalitis and the degree of meningeal involvement and degree of encephalon involvement or the encephalitis involvement, it varies. So sometimes in viral meningoencephalitis, the predominant affection of the brain is there with minimal involvement of the meninges. So in that situation, you may not get the meningeal signs. Only the encephalopathy changes, fever with altered sensorium will be the main presentation, plus minus seizure. Seizure is absent in your case.
Yes, sir.
But the bacterial meningitis, although you are giving more weight to the bacterial meningitis, they usually involve the meninges as well. So meningeal signs of meningeal irritation is usually present in bacterial infection. Only the encephalitis component predominant by bacterial infection is not possible. So yeah, the viral etiology is also more likely, not the bacterial etiology. The viral infection can also give rise to high fever. So presence of high fever doesn't exclude the viral infection. So probably this is the brain involvement, brain parenchymal involvement is more in this child. So that is why the signs of meningeal irritation are lacking. This is the explanation. And I should put more weight towards the viral infection because the predominant affection of the brain indicates the viral infection usually. And bacterial infection usually associated with especially in a 10-year-old boy, signs of meningeal irritation, which is not present in this child. Okay, any other possibility other than these two?
I'll request Dr. Odunoti Banerjee to give her expert comment. Dr. Banerjee.
Yes, sir. Thank you. So it was quite an enriching discussion. And from what we learn is, like as sir has said, that definitely this child had less of meningeal involvement, and therefore the neck signs were minimal. In fact, they were not there, whereas the cortical signs were more. So this definitely, because of the presentation of more involvement of the brain parenchyma, so obviously viral comes more, but of course such dense hemiparesis stroke associated with fever usually, and such high fever also we can get in viral, but then stroke, such dense hemiparesis is quite uncommon in, I won't say uncommon, like there is nothing called uncommon, but we usually do not get it in virus, viral encephalitis. Common viral encephalitis that we see like in this herpes encephalitis, it usually presents with seizures. Seizures is a dominant possibility, whereas in JE and all, they usually affect the basal ganglia. So there is more of dystonia and movement disorders. And if we have influenza and para-influenza and things which are going on around, so they involve more of thalamus, and therefore the encephalopathy is also more deep. And such focal neurological deficits we usually do not get. But then, of course, there are exceptions to the rule. So in that case, like we weighing between virus and bacteria, yes, I would give more score towards the bacteria. And the other point which I would like to make, that is falciparum malaria usually causes a pervasive loss of, drowsiness and loss of consciousness, kind of. It doesn't cause focal neurological deficit more so. So it usually causes a pervasive altered sensorium, which we see in falciparum malaria. So this is so as Deblina has elaborated. So we just came across an infection, and yes, as sir is saying that this can be a spectrum of AES. It would not be incorrect to call it an AES with a complication also of stroke.
Okay, I think 15 minutes is late. So next the investigation interpretation to be done.
Somebody has asked about what is the residence of that particular boy. Can
residence. Deblina, can you say where was the child from?
This particular, the child was from Hooghly.
Hooghly is a big, big.
The exact place.
Proceed. Otherwise, you won't be able to finish in by 15 minutes. Because
Yes.
just investigation, just in there.
Yes, you just tell the positive features.
So the child ultimately had a right-sided hemiparesis, right-sided facial upper facial nerve human palsy with altered sensorium and vomiting history of multiple episodes of vomiting and headache. So although the altered sensorium and history of vomiting, altered sensorium is more pointing towards a cortical lesion, but and also there was absence of any anesthesia, but this as the child had ultimately on further neurological examination, there was no deficit in the higher mental function, and also awareness and alertness in this child was preserved. So I would further interpret the site of the lesion as the internal capsule. So following looking to towards the blood investigations of the child, initially the child needed an ICU with admission, and we had monitored the arterial blood gas and the initial count, which were found to be raised leukocyte leukocytosis 18,200 count, which was neutrophilic predominant, and although the CRP were negative, the liver function test was within normal limit, but the renal function test was altered, and coagulation profile was within normal limit, but we found leptospira IgM was reactive in this child from the blood examination, and anti-beta-2 glycoprotein in the APLA profile was found to be abnormal. Otherwise, all the rest of the APLA profile and the vasculitis panel and the CS were all came into be within normal limit. Also, the other infectious origins like malaria, dengue, and scrub typhus IgM are found to be negative. The other imaging and CSF studies showed CSF study showed that 130 cells per millimeter cube, monomorph 35%, polymorph 65%, while Gram-stain, Z-stain, and culture were negative. The neurotropic viral panel were negative. The 2D echocardiography were also done to rule out any cardiac abnormality, and CSF PCR was also found to be positive for pneumococcus. Now, from the MRI brain, the T1 lesion, the T1 MRI was showing hypointensities in the left-sided basal ganglia region. The T2 showed hyperintensities on the same region, left-sided basal ganglia, and also the flare. Also, the diffusion restriction were also seen in the similar region. So ultimately, the provisional diagnosis
Please mute.
can be demonstrated as this is the acute right-sided hemiparesis with right seventh nerve palsy, which is upper motor neuron type. The topographical lesion in the left-sided internal capsule, the pathological lesions resulting from the thromboembolic phenomenon or stroke, arterial in origin, and probably the site of the artery may be the middle cerebral artery, as the predominant artery supplying the posterior limb and genu of the internal capsule, and the etiological lesion may be infection associated with arteriopathy. We found bacterial in origin, Streptococcus and Leptospira, both pathogen was identified. So from the treatment part, initially the child was admitted in the PICU with oxygen support was needed. Child was treated with the CNS protective strategy, maintaining the hypoglycemia, thermal temperature in this child, and multiple antibiotic suspect was also given, initially suspecting acute encephalitis syndrome. Then the drugs were also needed to be adjusted
Okay, I
according
think
to
you should stop the treatment portion, Devlina. This is only the clinical exercise, I think. The
Yes,
purpose
yes.
of the purpose of the meeting, I heard that this is only clinical. So just you hold the clinical treatment portion. My point is that I went through the investigation. The anti-beta-2 globulin level is high. And Leptospira and Streptococcus pneumoniae came out in the bacteriological analysis. And CRP is also normal. So this is infective etiology. The CRP normal, anti-beta-2 glycoprotein is high. So any discussion or any suggestion from your part? So because you have treated the child, so the investigation abnormality.
CRP should not be relied as an individual mark for infection.
And what about this anti-beta-2 glycoprotein?
Anti-beta 2 glycoprotein is one from among the APLA panel, but it is holding no value as a singularly. It is not holding any value. So cardiolipin and anti-beta 2 glycoprotein and lupus anticoagulant, all three should be tested together for the APLA.
Okay, but my point is that this is infective etiology. So the exhaustive investigation for childhood stroke, are they needed? If it is a case of acute encephalitis syndrome or bacterial meningitis, whatever it may be.
Sir,
sometimes this bizarre abnormality come and that will create problem. This is my suggestion.
okay, sir.
MR angio done or not? Someone asked.
Yes, MR angiography was done in this child, but that was not showing any abnormality in any artery, any arterial pathology. It's not shown.
I think time is very short. Yeah. Arundhati, please sum up, give your expert opinion regarding investigations and all, and please wind up the case.
Yes,
Another point from me, or the Devlina, when you
Yes,
have got the anti-beta 2 glycoprotein positive, sometimes the APLA or the collagen vascular disease, they get precipitated by some infection. So this child should be kept under regular follow-up. So if there is any feature of APLA syndrome, the thorough investigation in that line should be carried out.
yes, sir. The child is in
Sure.
regular follow-up, and also I have included one slide, and I have examined 1 year after the illness in this child, which was
yes, you can show the photo. You can show the photo, Deblina.
also
Yeah, you can show
the
the slide.
child. Yeah, this is initially just 2 weeks later the child's admission. Then it is 1 month later, and now this is the child a year later.
Okay, thanks. Thanks.
So now the child is ambulatory with minimum deficit. And so yeah, we had this child with infection associated stroke as a complication of AES, as sir has rightly pointed out. And yes, in this case, when we are getting a clear-cut infection with a PCR positive of pneumococcus, therefore extensive workup is definitely not mandatory. But here we have got a beta-2 microglobulin, which is like marginally elevated, so we can always repeat it and keep the child on follow-up, and the child is on rehab. And the other thing is, like, in order to rule out, because focal cerebral arteriopathy or transient cerebral arteriopathy sometimes is very difficult to distinguish acutely from other arteriopathies, then what is suggested is we have a thing called vessel wall imaging, in which in vessel wall imaging we can actually see the hyperintensity in the acute stage, and that passes off at 6 months. So if we can repeat it and we see that this vessel wall imaging has normalized, then it is suggestive of, like surrogately, it is suggestive of focal or transient cerebral arteriopathy rather than any other arteritis which may be complicating the scenario. So with that, we would like to end this session of this case, and we would like to shift to the next case, ma'am, with your permission.
Yes, very good.
So,
Thank you, Deblina. Wonderful, Deblina.
Thank you.
Very
Okay,
nicely
thank you,
presented,
Deblina. Thank you, Deblina.
Thank you. Thank you.
So for the next session, we have a very interesting case of neuroregression again. And to present that, we have Dr. Sanjukta Saha, who's a bright resident from 3rd year. And so may I call upon her to present your case? Sanjukta, please.
Thank you, ma'am. With your permission and all due respect to the present faculties, can I please start my presentation? Hello, ma'am. Am I audible?
Yes, audible, visible.
Yes, Sanjukta, you please share your slides so that
Yes,
we can find out whether you're visible or not.
I am here to present a case of a child called Alifsa Khatun, 10 months old, female, belonging to the Muslim religion, living in Bhagwatipur, Hooghly. The informant was mother, whose reliability was good. She had the chief complaints of loss of achieved milestones for the last 2 weeks, abnormal movements of the limbs for the last 10 days, associated with feeding difficulties for the last 7 days. The child was apparently well 2 weeks ago when she had... Sir? Hello? The child was
Continue, Sanjukta, continue.
Please carry on. Please carry on.
The child was apparently well 2 weeks ago when she had a gradual onset progressive loss of previously achieved milestones. It was initially associated with inability to stand and frequent falls, followed by inability to sit with and gradually without and then even with support, and then it progressed to head lag since the last 7 days. It was not associated with any swelling or any changes in the limbs. There was abnormal twisting movements of the all four limbs. The mother says that the movements were more prominent in the upper limbs as compared to the lower limbs. The frequency remained same all during the day, and they decreased quite a lot during sleeping. The mother also said that while changing the clothes, she had found a slight stiffness in the upper limbs of the child. The mother says that there was feeding difficulties in the form of occasional nasal regurgitation of feed, which was more prominent to liquids as compared to solids. However, there was no change in the volume of crying of the child. There was a history of fall from bed 2 weeks back, which was about 1.5 feet high, but the child did not require any hospitalization. She took consultation from the local doctor. There was no history of bleeding or loss of consciousness or altered sensorium or convulsions following the same. There was no irritability, bleeding, vomiting, loss of consciousness, altered sensorium, like I've already said, no seizures, no exaggerated response to usual sounds, no fever, no alteration of sleep cycle, no bladder or bowel problems, no abnormal body odor as noticed by the mother, no abdominal distension or GI disturbance in the form of vomiting, loose stools, or constipation, or skin changes. There was no jaundice, no history of drug intake, and there was no vaccine that was taken recently. In the past history, we have found no similar episodes. There was no major or significant medical or surgical history in the child, no history of hospitalization. She was born out of a non-consanguineous marriage. The mother was a booked case. She conceived the child at 24 years of age, while the father was 34 years of age at that time. And she received 4 antenatal visits and had done 2 antenatal USGs, which according to her were normal, although no documents received. 2 doses of tetanus toxoid was taken before the delivery. It was a term delivery, institutional. The child weighed 2.7 kgs and was born via the vaginal route at 38 weeks. However, there was a delayed cry after birth, responding to tactile stimulation. It did not require any SNCU stay, and the child was given to the mother for breastfeeding 1 hour after the delivery. There was no complication during the postnatal period, according to the mother. The development history in the pre-morbid time, there was no pre-morbid developmental delay according to the mother, and before the illness, the mother says that she could stand without support at 9 months of age, with support at 9 months of age, and could stand without support for 10 to 20 seconds at 10 months of age. Pincer grasp was present at 9 months of age. The child could speak bisyllables non-specifically like Baba at 9 months of age. There was social smile at 3 months of age and separation anxiety at 9 to 10 months of age. However, after the onset of the illness, there was a gross motor delay. The back was rounded while the child was held sitting with considerable head lag. The child could not hold the neck in position, and the DQ in this gross motor sector is 15%. In the fine motor section, she could open her hands frequently with only slight grasp reflex, and the developmental age is at around 8 weeks, and the development quotient is 20%. The language delay was she could babble. The developmental age would be 6 months, so the DQ would come around 60%, and the social and cognitive arena was not much impaired because separation anxiety and stranger anxiety was still present. The DQ would be around 80 to 90%. In the immunization history, we can see that she received the birth doses of the vaccines, and according to the mother, the BCG scar is present on the left upper arm, and she was completely immunized till date according to the national immunization schedule, and the mother could produce the mother and child protection card. She was exclusively breastfed till 6 months of age, and complementary feeding was started at 6 months of age. Her daily calorie intake is around 700 kilocalorie per day, and she takes both vegetarian and non-vegetarian food. The calorie deficit is around 17%, whereas the protein deficit is around 24%. In the family history, she was born out of a non-consanguineous marriage. There was one previous miscarriage at 2 months of age, which is spontaneous. There are no similar illnesses in the history, and no family history of epilepsy or unexplained childhood death. There is no contact history of TB. In the socioeconomic history, the child lives in a Pakka house with her mother and father. The father is an office worker. The mother is a housewife. Cross ventilation and toilet is present in the house. They belong to the lower middle socioeconomic class according to the modified Kupuswamy scale. So should I proceed with the anthropometry?
The experts, please comment on the history and
Actually,
Yukta,
Yes, sir.
the history portion is complete. So from the history,
Yes, sir.
so what are the possibilities you should keep?
So from the history, I would like to point out that this child had a loss of previously acquired milestones. So we can very well label it as a case of neuroregression. There are no other features suggestive of pseudo-regression, as in the child did not have any previous chronic diseases that would cause a chronic meningoencephalitis or any neurological deficits that would give rise to secondary problems that could have given rise to pseudo-regression. So I'm considering this a case of true neuroregression. Along with that, the mother is saying that it started occurring at around 9 months of age with an insidious onset, but it was gradually progressive. And it is involved, it has some involuntary movements all over the body, as told by the mother. So it might involve the extrapyramidal system as well. So I am thinking of a neurodegenerative or a neurometabolic cause. Sir, tell me.
What is the mode of onset over here? 2 weeks duration only.
Yes, sir. 2
The
weeks duration.
whole
Yes, sir.
duration of the illness is only
Yes,
2
sir.
weeks.
Yes, sir.
So is it sudden onset?
No, sir, it was not sudden onset. Initially, what happened? The child, she had the inability to, she could stand before the illness. The mother said that she could not stand, and it progressed from there, and it progressed very fast.
so
Actually, the Ashok sir say something.
I like to ask, what are the different types of developmental delay we observe in our day-to-day pediatrics examination? What are the different types of developmental delay, and in which category this particular case falls?
So the developmental delay can be, sir, an isolated developmental delay or a global developmental delay. So
I should
if there
say, there are 3 types of developmental delay. That one is static developmental delay,
yes,
another is progressive developmental delay, and another is acute developmental delay.
yes, so this would
Now,
be
what is the type of delay?
so
Here
this
is-
would be since the disease is still progressing, it will be a progressive developmental delay of acute onset.
acute onset. What is the difference between the acute developmental delay and progressive developmental delay? With example, can you tell me?
Sir, here, if we draw a developmental curve, sir, the
Ah.
progressive developmental delay will follow the will what happens is it will follow the line, but it will be at a lower rate. But what happens is in acute, sir,
Hello. Sound is disturbing.
Lost connection, I think.
Lost connection.
Sanjukta, you are having connection problem. Hello,
The expert
Sanjukta.
can now highlight about this type of delay. So can you explain these 3
Hello?
type of delay?
Actually, Sanjukta is
yeah,
coming again.
Yes, he has come.
sir, I did not know what happened, how I got disconnected.
Again,
Okay, no problem. No
Be,
problem.
be comfortable. Be comfortable.
Yes,
No problem.
sir, I don't exactly know what happened. I'm really sorry, sir.
Ah, okay.
Sir, is it visible?
Visual, very nicely visible.
Yes, sir.
Now,
Sir, what I was saying was, if we see a normal development curve, sir, it will be a linear rising curve. In case of a progressive developmental delay, there will be a progressive drop in the curve. In case of a static development delay, it will initially decrease, but then it will become static, as in case of a cerebral palsy. But in acute, it will initially follow the normal developmental curve, but then it will suddenly drop down.
Okay, Sounjit, that answer I like to hear from you. Very good answer. Now, from that curve, in this curve,
Yes.
as you say,
Yes,
this is a progressive development delay.
yes,
Only one disease can explain you this progressive developmental delay. What is that disease? Or that group of diseases? Tell me.
Sir,
Only one.
Sir, I am thinking of an acute onset with a progressive developmental delay. I was
Uh,
thinking of, mitochondrial diseases.
Any neurodegenerative disease.
Yes, sir. Any
Okay.
neurodegenerative
Okay.
disease. Yes, sir.
Next important history is that usually neurodegenerative diseases may start earlier, I think.
Yes, sir.
In some cases, not all cases, in some cases. But here the disease started after, say, 6 months of age.
Yes, sir.
It started almost 9 months or 10 months, and
Yes,
the
sir.
progress
Yes,
is
sir.
very rapidly.
Yes, sir.
This also give you some hint also this.
Yes, sir.
And there is global involvement is there.
Yes, sir.
Okay, proceed.
Yes.
Neurometabolic, I think.
Yes, sir.
Neurometabolic
Neurometabolic.
disorder,
Yes.
usually onset occurs early, but it's
Yes.
a bit late.
Yes.
Okay. Okay.
So I shall proceed with the anthropometry. We can see that the weight is 8.5 kg and the expected weight would be around 9.5 kg. But according to the WHO weight for length chart, it lies between 0 to 1 -1 standard deviation. The length is 73 centimeter, which lies to 0 to +2 standard deviation according to WHO weight for length for age chart. The head circumference of this child was 45 centimeter. That lies between 0 to +1 standard deviation according to the WHO head circumference chart, and the mid upper arm circumference was normal at 14 centimeter. So so here is a schematic diagram that I had made, and that we have already. Shall I go to the general examination, sir?
Okay, carry on.
Yes. During the examination, the child was awake and was lying supine on the bed in a comfortable position. However, there were generalized involuntary movements, involuntary twisting movements of all 4 limbs, and the child was interacting with the mother by cooing. There was no pallor, icterus, clubbing, edema, or lymphadenopathy. In the vitals, we saw a normal temperature, and the pulse rate was 102 per minute, regular, with normal volume, without any radioradial or radiofemoral delay, and was equally palpable in all 4 limbs. The respiratory rate was 36 per minute, and it was thoracoabdominal in nature. The blood pressure was 86 by 48 millimeter of mercury, which was between the 50 to 98 centile. In the head to toe examination, we found that the shape of the head was normal. There was no facial dysmorphism, and the hair was normal. There were no neurocutaneous markers in the body. There were no skin changes. No hypo or hyperpigmented patches were present. There were no bed sores, no contractures. BCG scar was present on the left upper arm. Now we are coming to the neurological examination proper. In the higher mental function, the child was awake, and the modified Glasgow Coma scale was 15 by 15, and she was interested in her surroundings, and she recognized her mother and interacted by cooing. There was no hand preference in the child. In the cranial nerve examination, the cranial nerves examination was essentially normal. So should I further elaborate the examination, or should I just move forward?
When the normal, there's no need to elaborate, huh?
They were normal. There was no abnormalities found in the cranial nerve examination. In the motor system, we found that the muscle bulk was bilaterally symmetrical in all 4, bilaterally symmetrical and maintained in all the limbs. The tone was bilaterally symmetrical and increased in all 4 limbs, and it was velocity dependent, so I'm calling it a spasticity. It was more in the upper limbs as compared to the lower limbs. The power was bilaterally symmetrical, spontaneous limb movements were present, and anti-gravity movements were present.
Deep tendon reflexes were brisk and bilaterally symmetrical. Superficial reflexes, the abdominal reflexes were present. However, the plantar was bilaterally non-responsive. The gait could not be assessed in this child. Dystonia was present in all four limbs in the form of abnormal twisting movements with sustained contraction at times. Sensory system was within normal limits. There was no nystagmus, no overshooting, so the cerebellar signs were absent. There was no autonomic dysregulation, and the signs of meningeal irritation could not be elicited. The skull and spine examination was within normal limit. The other systems that I had examined were the CVS, respiratory, and the GIT. I did not find any significant changes in any of them. There was no hepatosplenomegaly in the respiratory system. She was bilateral vesicular breath sounds were present in all the lung fields, and there was no features of any crepitations. In the cardiovascular system, there was no rhythm abnormalities. The apex was in the normal position, and first and second heart sounds were audible in both cases. So should I go forward with the summary?
No. Before
Wait.
that,
Yes, sir.
before that, wait.
Yes, sir.
Before the summary, the nervous system examination is showing the child is having dystonia.
Yes, sir.
You mentioned spasticity. The
Yes, sir.
spasticity indicates corticospinal tract
Yes,
involvement,
sir. Yes, sir.
but you mentioned that the plantars are flexor. So it's
Plantars are non-responsive.
normal responsive. So it's not really
Non-responsive, sir. It was equivocal, sir. I could not say whether it was responsive or not. The plantars bilaterally.
not elicitable then.
Not elicitable, yes, sir.
Not
elicitable.
elicitable.
Yes, sir. Plantar not
Okay,
elicitable.
okay. So I thought this was a flexor. Okay,
No, sir.
normal response. NR was written over there, probably normal response.
Oh, sir, I had
Hmm?
more. I wrote non-response. I should have written not
Non-response.
I should have written not elicitable. Yes.
Okay, from the nervous system examinations, what are the parts of the brain which seem to be affected here?
Yes, sir. Certain things, sir, that are being, sir, I'll come from the top. Sir, most probably there is no cerebral cortical involvement, as there are no convulsions in this child. There is no cognitive impairment. First, so second, there is we could not find.
Cognitive impairment, how can you say? The child was responsive initially, now the response has become less, only the cooing with the mother.
Yes, sir.
Initially, the language the child used to say Baba, Ma.
Baba. Yes,
Now only babbling is there. So cognitive impairment definitely is there.
Cognitive impairment. Yes.
That is there, cognitive.
But sir, there are no convulsions. So
no convulsion is there, but
no
the dementia portion is there. So you cannot say that the cortical involvement is not there. It may be there.
Yes, cortical involvement.
First.
Yes, sir. So second, there is generalized dystonia in this child. So most probably the basal ganglia, that is the extrapyramidal system, has been involved. So third, I can also see that there is spasticity, not rigidity, rather there was spasticity, and deep tendon reflexes were bilaterally symmetrical and brisk. So there might be an involvement of the long tracts, that is the corticospinal tracts.
Corticospinal tract.
Yes, sir. And yes, sir. Most probably a UMN lesion.
Most probably human lesion. Corticospinal tract means the human lesion.
Yeah, yes, sir. Not most probably. I should say
corticospinal tract.
UMN lesion of the
if it is neuro metabolic disorder showing the acute onset as well as the progression, less than 2 years old child. So what are the disease possibilities in this age group with this sort of presentation?
So it can be divided into a gray matter involvement or a white matter involvement, as well as a basal ganglia involvement. So in the gray matter involvement, sir, in this child it would be unlikely because there is no hepatosplenomegaly, but GM1 gangliosidosis or Gaucher's, they can present at this younger age group, or certain mitochondrial disorders in which muscle involvement can also be present. In the white matter diseases, we have not found the microcephaly, but had we found microcephaly, Krabbe's would have been a possibility. In a normal or a large head, so metachromatic leukodystrophy, though it is more common in the older age group of 2 to 5 years, and certain mitochondrial disorders and amino acidopathies like glutaric aciduria, they can be, sir, the possibilities.
Neurometabolic disorder,
Yes, sir.
where the hepatosplenomegaly is usually not found.
Yes, sir. So neurometabolic disorder.
Any,
Yes, sir.
the possibility of infective illness?
Sir,
Fever
infective.
is not a necessity over here.
No, sir. Fever was not present, so that is why we were
The
not.
duration of the illness is only 2 weeks. So
Yes,
any
sir.
infective etiology you should keep under
Uh,
the differential diagnosis.
Sir, actually, the infective etiologies that would cause the neurodegenerative disorders, so they also have to be, they should be a chronic pathology. For example,
Only
it
2
can
weeks.
be
Your total history is only 2
only
weeks.
2 weeks. Yes, sir. Otherwise, sir, I would have thought of, sir, retroviral meningoencephalitis, things like that, sir, but I didn't think of that.
I do
But
not
since
know
it's
the
effective,
what are the usual presentation of the retroviral infection.
Here I can
in
comment. In
child.
retroviral infection, there will be some involvement of the gray matter also.
Yes.
Not only white matter. Encephalopathy is the important part, and usually global developmental delay or regression both can be there in HIV.
and since there was a little bit of cognitive impairment as well, so that is why I was thinking.
What
No,
about the
no.
anterior
No,
fontanelle? Did you mention about the anterior fontanelle?
Sir, yes, sir. I had examined the anterior fontanelle. It was still open. It was 1.5 centimeter into 1.5 centimeter in measurement. The posterior fontanelle was closed.
Any sign of raised ICT in this child?
So no, sir. There were no signs of raised ICP. I could not, sir. According to the symptoms, I could not find any irritability or significant altered sensorium. Or according to the mother, there were no convulsions.
Fontanelle bulge or normal?
No, sir. Fontanelle was flat, so it was not bulged.
Now, Samyukta,
Yes, sir.
hello.
Yes, sir. Yes, sir.
Also,
Hello.
Hmm.
Tell me clearly,
Yes, sir.
will you think the gray matter involvement, cortex involvement in this case, yes or no? Answer.
No, sir.
Huh?
No, sir.
No or yes?
No, sir. I'm not
No.
telling you.
No. Second, you tell me now when the subcortical structures are involved. Is it yes or no? Yes or no?
Sir, I won't be able to comment.
Subcortical structures involved, yes or no?
No, sir. They have not been involved subcortical structures. No. So there is no, sir. There are no weaknesses. Sir. There is no focal neurodeficit. There should have been a focal neurodeficit had the subcortical structures or the cortex been involved, or there had been convulsions.
What are the subcortical structures you know in clinical importance? Subcortical structures.
Sir,
What you consider about the
sir, the subcortical. Yes, sir. Sorry, sir. So my mistake. Sir, subcortical structures. So they are the thalamus,
definitely
putamen.
involved.
Yes, sir, definitely involved because this is
Definitely
always involved. Sir,
involved,
my
but
mistake, sir. Sorry,
but so there are the large number of
Yes,
subcortical
yes, sir.
structures. They are definitely
Sir,
involved.
yes, sir, they
Let's
are
tell
involved.
me
Yes, sir.
which group of subcortical structures involved in your case?
Sir, they are causing dystonia. So, sir, the basal ganglia region must be involved.
Now, how can we explain the failure of say plantar, plantar incitation in a case of dystonia? What is the effect of dystonia on plantar reflex?
Sir, in a plantar reflex.
Actually, what is dystonia? You tell me what is dystonia.
Yes, sir. So dystonia is an involuntary movement. So that occurs due to a certain sustained contraction of the sustained involuntary contraction of both the agonist and the antagonist muscles.
Very good. So protagonist and antagonist muscles,
Yes,
they
sir.
will contact.
Yes,
so
sir.
definitely when you try to elicit
Yes,
the
sir.
plantar reflex, then definitely the muscles which are against,
Yes, sir.
they will give rise to, they will prevent your
Sir,
the response.
at less than 1 year, it is a bit difficult to comment upon the.
Now, whenever there is any, it is correct. Your answer is correct, but remember, whenever there is any neurological definite lesion is
Yes, sir.
present,
Yes,
and
sir.
whatever may be the age of the patient, even if it is 3 months or 4 months,
Yes, sir.
the plantar reflex is important.
Okay, sir.
Okay.
Yes.
If there is any other neurological signs are not present,
Yes, sir.
then it is not important. But whenever
Okay,
the
sir.
responses are present, problems are present,
Okay,
then
sir.
it is important.
Okay, sir.
And in a case of dystonia, it is very difficult to elicit the reference.
Yes. So I should have written non-elicitable, sir. It was my mistake.
Yes, yes.
Not elicitable.
And now, will you think about the other types of, say, basal ganglia involvement?
Yes, sir.
What are the causes of usual basal ganglia involvement?
Sir, in the older age group, we will have the most common.
Forget about this age group is only 10 months.
This age.
Sir, only 10 months.
10
At
months.
this
You
age,
just at this age, tell me what are the causes of basal ganglia involvement?
sir, at this age group only.
Ah.
Okay, sir. Sir, at this age group, the most common causes for this would be the mitochondrial defects and certain amino acidopathies. And sir, Wilson's, but it usually presents in the older age group.
Sanjukta,
Yes,
there's a
ma'am.
question from Professor Nayak. What's
Yes,
the head size
Yes,
and
sir.
cherry red spot?
Sir, the head size was 45, and the head size was 45 centimeter. And sir, it was lying between between the 0 to +1 standard deviation according to the WHO head circumference for age chart. And sir, on ocular examination, sir, we did not find any abnormalities in the fundus or in the macula, so we can say that the cherry red spot was absent.
Sanjukta, tell me some important causes of basal ganglia involvement in children.
Sir, yes, sir. Wilson's disease can cause basal ganglia involvement. Along with that, sir, it can be pantothenate kinase associated neurodegenerative disorders, and sir, glutaric aciduria.
Yes.
Sir, I can think of these.
Any infection, any other disease?
Tell me other important disease, not common to this age. I told to ask you in general, not related to 10 months age or others.
Sir, Leishman syndrome is also present. But sir, I do not remember anymore.
Any common disease which is detected, thought rarely, but it is not uncommon.
Yes.
Nowadays also.
JE, Wilson,
Infection.
HIV, all causes.
Ma'am, I said Wilson's.
Madam answered on behalf of.
Actually, no, not madam answer. Samita Sarkar, another PGT has written JE. Good.
Okay,
So
good.
other residents are requested to answer in the chat box.
Yes. So good, Samyukta, proceed. I think Dr. Supratim
another thing, Sanjukta, the JE is there, which commonly affect the basal ganglia.
Yes, sir.
What about our good old friend, Mycobacterium tuberculosis?
Sir, it can affect anything.
So
The child is 10 months old and 2 weeks duration.
Yes, sir.
The child presented with
Basal
dystonia.
ganglia impact can occur in tubercular meningitis.
Samyukta, this is very important input. Please remember, very important. It can do anything.
Yes, sir.
Anything, any type of presentation.
Yes, sir.
But
definitely the basal exudate and other things, they will come later. But remember, tuberculosis of the brain may present any type of presentation.
Yes, sir. Yes, sir.
although this is said that the subthalamic nucleus of lice are more affected in tubercular meningitis, but still it can affect the basal ganglia, and the dystonia could be the presenting feature. So the duration of illness is only 2 weeks. So you should keep in the differential diagnosis,
Yes,
this
sir.
thing.
Yes.
The infective etiology, other than the neurometabolic, infective etiology should be kept.
Yes, sir.
Okay, proceed.
So should I say the summary or should I skip?
Yeah, the time is constant, I think. So summary, you just tell us the summary. Okay, no problem. Okay.
Yes.
Okay.
10-month female who was well nourished, completely immunized according to the age, firstborn of a non-consanguineous marriage, who was previously developmentally normal with delayed cry after birth and no significant family history, presented with insidious onset, gradually progressive neuroregression since the last 2 weeks, associated with generalized dystonia and feeding problems in the form of occasional regurgitation of mostly liquid food without any convulsion or cognitive impairment. She has spasticity of all 4 limbs, which are bilaterally symmetrical, and upper limbs are involved more than lower limbs with brisk, deep tendon reflexes without any features suggestive of sensory, autonomic, or cerebellar involvement, micro or macrocephaly, hepatosplenomegaly, or aspiration pneumonia. So this is my summary.
Diagnosis.
Yes.
My professional diagnosis is this is a 10-month-old, well-nourished and completely immunized child having neuroregression with spasticity and generalized dystonia. The lesion most probably involves the basal ganglia and white matter due to a neurometabolic disorder without any vision or hearing impairment.
Comments from experts.
What are the I mean the genetic disorder
Yes, sir.
which can which can affect the basal ganglia and this sort of dystonia?
Yes, sir.
One is the glutaric aciduria you said,
sir.
and the mitochondrial you said.
Yes, sir.
Mitochondrial glutaric aciduria.
Yes.
Other than this,
Sir, Leach-Nyhan syndrome can also cause basal ganglia symptoms. Along with that, we have the panthogenate
affects the male child. This is a girl child. It
Yes,
affects the male child. Leach-Nyhan syndrome. And
sir,
what about the primary generalized dystonia, the torsion dystonia, or all those things? The presenting feature is dystonia only.
Yes, sir.
With delay or regression.
Yes, sir. Primary dystonia.
Dopa responsive dystonia.
Sir, it would generally present at a little bit of older age.
Older age group. It can affect sometimes the younger age group also.
Yes, sir.
So this is another one. And what about the drugs? History of intake of any drug. Sometimes drug can give rise to dystonia. Any intake of drug intake? Did you keep in the history drug intake?
Sir, I said there was no toxin ingestion or any. Sir, I wrote that.
What are the drugs which can give rise to dystonia? The commonly used drugs?
Sir, they are the antiemetics like prochlorperamide or certain anti-arrhythmic drugs. So they can give rise to dystonia. But their use is uncommon in the child. However, there can be heavy metal poisoning.
Drugs, metoclopramide or other the antipsychotic preparation.
Yes, sir, antipsychotic. So like sir, amitriptyline or tricyclic antidepressants. So these, so reserpine.
Another metabolic disorder, biotin responsive basal ganglia disease.
Yes, sir.
The importance lies over there. It promptly responds to biotin.
Yes, sir.
Plus thiamine. So
yes, sir.
It affects the basal ganglia.
Yes, sir. Sir, but in that we should have found certain skin changes like dermatitis, conjunctivitis, alopecia, or there would have been a hypotonia with lethargy. So we should have expected those things in a biotin responsive disorder, but it is a possibility.
We had one suspicion about the biotin responsive basal ganglia disease.
Yes, sir.
So the genetic study was not possible. We kept the child under biotin and thiamine, and the child is showing good response.
Yes, sir.
So
sir, actually, this child also sir received actually levocarnitin and riboflavin, and this child was finally diagnosed as glutaric aciduria type 1, and sir by a TMS GCMS screening.
My suggestion is that any child presenting with predominant dystonia, so investigation will prove the exact diagnosis, proper investigation. But most often, the clinician, they prefer to start levodopa as well as the biotin. So these are the two drugs to be considered with predominant presentation of dystonia, otherwise in a well-looking child. So these two are the possibilities. Biotin, the responsive basal ganglia disease, another is the dopa responsive dystonia. Although it affects the older children, but sometimes it can affect the young children also.
I think now this is the time to give comments from our mentor, Dr. Arundhati.
So, Sanjukta, thank you for a very nice discussion. I would just like to add that the other possibilities, like as sir has said, infective possibilities should also be considered, even though the child did not have fever. And as for neurometabolic disorder, we can also include cobalamin C defects or organic acidemias like MMA. Sometimes even the partial or hypomorphic forms may not present with acidosis or other clear-cut features of organic acidemia, but there can be dystonia and basal ganglia involvement. Dopa-responsive dystonia, yes, we do get. In fact, it is a dictum for any child having a lower limb dystonia. In a slightly older age group, we have to give a DOPA trial, which is mandatory, which should be the first step. But even in infancy, neurotransmitter disorders, which also behave like monoamine deficiency and other enzyme deficiencies, they can also behave in similar manner. And they usually present with autonomic hyperactivity and dystonias, and they are very difficult to treat. So, so these also should be included in one of in our differentials. And as for the treatment, yes, as
Arundhati, just show the investigations.
Yes, ma'am. I'll show.
Investigations.
In the investigations, we found that the routine blood count was essentially normal. There was no abnormality in the renal and liver function tests. The CRP was negative. The random blood sugar was 102 milligram per deciliter, and urinary ketone was 1+. Arterial ammonia and arterial lactate were 22 and 0.96 respectively. They were both normal. There was no acidosis in an arterial blood gas study. Homocysteine level was normal. It was done to think of the biotin indase deficiency. There was normal VP. Vera study was normal in both years. We went forward with the MRI brain. This is a flare axial section showing the deep gray matter involvement along with the periventricular white matter and striatum involvement. Here is a corresponding section of the axial T2 section, where we can see that the opening up of the transverse fissures of the sylvian fissures, giving a characteristic batwing appearance, and diffusion weighted image shows hyperintense signal changes in bilateral globus pallidus. So we have a neuroregression. We did not have a large head, dystonia and distinctive MRI changes, and we went for a TMS and GCMS. We found increased glutaryl carnitin and increased 3-hydroxyglutaric acid and glutaric acid in the urine GCMS, and the diagnosis was glutaric aciduria type 1.
Actually, in glutaric aciduria, the head side would have been enlarged, and there was widened sylvian fissure. So, can you show me the widened sylvian fissure? Possibly it was there. Yeah, it was there. But
sir,
the head size was 45 centimeters.
Head size, sir, what happens is it enlarges progressively. Initially, there might be a normal head size. Then there can be a relative macrocephaly, but ultimately the child will have a macrocephaly.
Yeah, usually in 4 to 5 years.
Yes.
Okay.
Yes.
Yes, as very
Excellent.
rightly pointed out, it can come later. And the typical features of bat-swing appearance, those usually come up more when we have a crisis situation. A crisis meaning when they are subject to any fever or any stress, then the MRI findings become more apparent. We can have subdural effusions, we can have subdural hemorrhages, we can have enlarged head, which later on develops and evolves. So this is just to highlight one aspect, that it is one of the treatable neurometabolic conditions. And therefore, if you get one, we can offer some amount of treatment which can improve the neurodevelopmental outcome to some extent, even though the child may not become absolutely normal, but definitely his milestones do pick up.
Dr. Arundhati, how did you treat this child?
So we have yes, treatable options. We have L-carnitine, which is usually given, and we have riboflavin, and these have been advocated, and there are also, formula which are available. So if that is very expensive actually. So what we can suggest is diet, which is low lysine and tryptophan reduced diet, and we can supplement. These supplements are very helpful because they help these kids to tide over any crisis situation. And crisis doesn't need to be like very severe. Even trivial viral infections, trivial fall can be a crisis situation for them. So if we put these children on carnitine and riboflavin supplementation, and if we tend to double this carnitine levels, normally we give it 75 to 100 milligram per kg per day. But in crisis situation, when they're having viral fever, it is always advisable for them to have a plan in which they themselves will double the dose of carnitine and continue on riboflavin. Then they will pick up their migraines. So this is one of the, somehow some amount of treatability is there in the options.
Exactly. Can you point out what is the price of this monthly expenditure?
Monthly expenditure will be huge, sir, because
it's not easily available, I think.
No,
It's not in, and Dr.
one thing,
Ashok,
one thing I like to ask Arundhati, when you give the carnitine supplementation orally,
yes,
the carnitine is mostly needed in all the cells, but specifically in the muscles, where your blood carnitine or serum carnitine is very difficult to enter in the muscle. Now, lecithin acyl carnitine transferase, LCAT, enzymes not sufficient. LCAT molecule is not sufficient enough in the muscular cells. Now, L-carnitine supplementation, if you give orally, is it sufficient to supply the muscles to counteract the muscle weakness or muscle requirement of carnitine? Number one. Number two, you are reducing the diet of tryptophan, no doubt. It should be, because tryptophan is one of the important component in the diet giving rise to butyric acid urea, type 1 particularly. Now, if the tryptophan is reduced, then your brain will be maybe not get the adequate amount of tryptophan. So serotonin may be deficit, and serotonin can get some neurotransmitter problem, lots of problem in the brain. How to counter these two aspects for the during the management of these disorders? Hello, am I audible?
Yeah.
Arundhati?
Yeah, you are audible, sir.
Arundhati
You are
is
audible.
there.
Arundhati, any comment on the Dr. Ashok's queries? She's
Connection চলে গেছে. Sangyukta, you tell me,
Yes.
just L-carnitine if you supplement orally, is it sufficient to supply adequate amount to the muscles which are needed?
during crisis.
During crisis, particularly lecithin carnitine acyl transferase enzyme, that is deficient during crisis. Second thing, the tryptophan should be avoided here. Now, tryptophan is very important for conversion, in the conversion of 5-hydroxytryptamine or serotonin in the brain. And serotonin, you know, the very important neurotransmitter in different neurological function. And also serotonin is very, very important nowadays. We are very much dependent on certain receptors. So how can we counterbalance these two with the restriction of this? Definitely that should be restricted.
the strict restriction of tryptophan is not possible in our diet, but we advise them. But generally, the patients are not able to stick to any diet, and the formula is very expensive. It is not easily available.
No,
So that
my question is how you can manage the brain functions with the very less amount of, or say, permissible amount of tryptophan.
So permissible brain functions such as irritability and sleep disturbances, they can be managed with melatonin or with small amount of benzodiazepine, which is given for dystonia and for the autonomic activation and the irritability or the sleep-wake rhythm abnormalities, which the child can suffer. And like L-carnitine, it is worldwide accepted. We have protocols in which we supplement it with 100 milligram per kg per day. So I take it that maybe the LCAT deficiency or that problem is circumvented, because I have patients on follow-up and they are behaving well, I mean, reasonably well on 100 milligram, and we can also double, because it is not feasible for us to put them on IV like carnitine supplementation every time or throughout their life, because these supplements will be for lifetime. Like we have to continue carnitine and riboflavin for lifetime. And then we have a protocol for emergency or crisis situation. Can you show the protocol?
Yes,
so we should increase the doses of this.
Yes, we can. And in fact, there are like published protocols to deal with emergency situations, and where the dose is increased, then we add metronidazole, you know, to help them in case of crisis situation. But in other situation, in baseline, 100 milligram is what is advocated.
Okay.
75 to 100.
I'll show the crisis management protocol. Just a second.
You just give a glimpse so that you know there are. It is freely available on the internet, so anybody.
Till then, Arundhati, there's another question. Think of autoimmune encephalitis with dystonia. Why not? It is autoimmune encephalitis with dystonia before, of course, before investigations.
Ma'am,
That is a clinical diagnosis.
first of all, I mean, the MRI actually told us it could be anything, but the
Yes,
age was
MRI
quite
does diagnose.
atypical. The
Yes.
age is quite atypical. I'm not saying I have not treated autoimmune encephalitis below 1 year, but the percentage is very less. If I have treated 50 patients of autoimmune encephalitis, then I have treated less than 5 patients who present in infancy. So before thinking autoimmune encephalitis in a child with dystonia in infancy, please investigate. If we do not have anything, then those are the treatable options that we have to find. This is, I think, what I would like to see.
Okay, now thank you, Arundhati.
Okay, thanks all the participants, all the 2 PGTs for good presentation. The cases were very high, and thank to the mentor also. Thanks, Ashok sir, for being with us, and thanks
Thank
the
you,
whole
Supratim.
organizing team, the 2 president, secretary, as well as the scientific chairperson, and all the office bearers of IP. Just my suggestion is that if you put a calendar, which institute is to take the responsibility of this clinical presentation. And my request to all the faculties and the members that as far as possible, the clinical exercise emphasis is to be given to the clinical exercise in this sort of presentation, rather than the typical case presentation as happens in IP clinical meeting. Okay, thank you. This is my suggestion.
Thank you,
you
Dr.
very much.
Supratim Datta,
Thank
for
you
your
very much.
Thank
yeah,
you,
yeah.
sir.
Thank you, sir, for your bright
Actually,
idea and guide.
tomorrow we will have our monthly clinical meeting. That is the physical clinical meeting in Chittaranjan Sevasadan in Department of Pediatrics. And on 31st, we have got it. That would be held in Kolkata.
Okay,
We will reach to the remote places. On 31st, we will have a online
okay,
meeting
before.
at Mission Hospital, Durgapur. So I will request all the audience who are present here to be present on those days if possible, particularly in the online and both in offline. And over to Kalpana, madam.
Yeah, I wanted to request before this announcement, actually, for this clinical session, we are really enriched with the experts and mentors and of course the presenters. They have presented very well, wonderful presentation, both the PGTs. And I also thanks all the PGT residents, faculty who have joined today, and our honorable guests are all. So I request all the faculties who are there here, please volunteer encourage your PGTs to volunteer and present the cases so that we can have, okay, as suggested by Dr. Datta, we'll have a calendar. But until unless the faculties facilitate their PGTs and they don't volunteer, it won't be successful. So I was very afraid at the beginning how far it will be there, but I'm really happy to see the attendance. It is quite high, and we expect much more. It should cross the 100. And
thank you, madam. Thank you.
Thank you, sir.
madam. Thank you.
We are in this with your questions, answers.